Okay. So in general, I have this little thing on pleural space in general. On some of one of the procedures that is done. I have this section on chest tube because chest tube can be confusing for a lot of people. And then I also have some practice questions. I think it's like oh, like a few practice questions to go along with it. So this is not the longest topic. It's just pneumothorax and pleural effusion. Correct me if I'm wrong on that, but that's just what I remember seeing on there. So pleural space is this little space in between, in little space in between the lungs, and uh, that allows it for to reduce like the friction. So when there's breathing involved, helps to reduce some of the friction because your lungs are going inflating and deflating. So that creates some friction. And the purpose of that is just as a way to reduce some of that and not cause any damage. Kind of like the pericardial space that your heart has. So it's not meant to be filled with much. It has about maybe like 10 to 20 mLs of fluid. But other than that, it's not meant to be filled with stuff. So the issues start to arise when you either have a pneumothorax, a hemothorax, um, or a pleural effusion. So, a pneumothorax is air that gets additional air that gets put into the pleural space. A hemothorax is blood in particular, and this can limit your lung expansion. So we can take a look at a hemothorax. This is basically like the idea here. And the same thing applies um when it's air or not. So you can see here at the lung is the black part. Will we need to differentiate them on x-rays? No. No, you don't have to worry about that. That'll be like, yeah, that your job. That's more like radiology and MD. You don't have to worry about that. But if you work on at like a floor that gets this a lot, I guess like an ER, I'm guessing would probably get this a lot. You will probably get good at it anyways. But no, you don't have to worry about that. But generally, the white is going to be fluids or air. So you can see here, this is the lung, and then this is the other half of the lung. So another picture here that is probably good. This one seems pretty good. Actually, this one's even better. So let's take a look. Where'd it go? Oh, they lied to me. That's crazy. I don't like that one as much. That's crazy that they have this one, but it's not the one that, or whatever. Okay. So, generally though, you can kind of see the idea. So this, because there's that little bit of space right here, and you can kind of see it. You can see the lungs right here, and there's this little bit of space right around here, where there's a little bit of fluid. But the point is just to decrease friction when the lungs expand and then deflate. But here, because either something got punctured, so trauma could be a cause of it. Sometimes you can have spontaneous, although it probably wouldn't be hemothorax for spontaneous. It would probably be more of a pneumothorax. Pneumothorax is the exact same idea except with air. So I believe it ends up being the like tall, skinny, skinny men are more likely to get spontaneous pneumothorax, as in like it just happens where for some reason or another that pleural space gets punctured or gets that layer gets broken through and then air leaks in it. And so what happens when that space opens up, it either gets full of air or gets full of blood. So For a pneumothorax, you can think of it as exactly the same thing. Just instead of it being red blood, it's wind. It's not wind, well, air. But the same idea applies. So the layer fills up with so much air, it starts to apply pressure on it starts to apply some pressure on the lung. And you can see that that pressure being applied to the lung means that lung is being crushed. It means they can't expand properly. And it also means there's not going to be good exchange of oxygen going on. So here it's showing a traumatic hemothorax. So you can see there's a little chunk here that's kind of missing. So this person had some sort of chest trauma, maybe got into a car crash and punctured the pleural space. Pleural space got filled up with blood. All that blood applied a ton of pressure onto this lung and is preventing the proper exchange. And here is a spontaneous hemothorax. So this one's uh, sometimes it can just happen just spontaneously. Same thing with like a pneumothorax. And I'll post this picture because it's pretty helpful, I think. So let's kind of go like that. And this one's pretty self-explanatory, but what is it going to be diagnosed by? It's going to be diagnosed by the chest x-ray. It's going to be your main one. It's going to be the chest x-ray. You can also try with ABGs because ABGs can show you like that there's some sort of acid-base imbalance going on, which in this case would be caused by the improper oxygen exchange. So you might be seeing those values be thrown off in an otherwise healthy person. But for the most part, it's going to be your chest x-ray, and you kind of saw that image there that showed you what it might look like. The general idea being that black is your lung, or like the darker is going to be your lung, while the whiter color is going to be your air or fluid of any kind. So I'll just take this picture here just so you guys can have it here. So you can very clearly see that going on there. Um, and then for the purposes of treatment and um, presentation, pneumothorax and hemothorax have the same signs and symptoms. What are some signs and symptoms that you guys can think of that you would expect with this going on?
Shorter breath, rapid respirations.
So you do dyspnea, shortness of breath.
Like unilateral, like there's gonna be like absence of breath sounds unilaterally.
Yeah, 100%. So that's gonna be a big one because some of these can be a little, I don't say totally vague, but especially as you guys keep moving forward and you get to some of the heart conditions, like some of the heart conditions that like the heart rhythm, the abnormal heart rhythms, some of those signs and symptoms are like pretty much the same between most of them. So it can get a little vague, and then you have things like a pulmonary embolism that has a lot of the same symptoms. So fast respiration, shortness of breath, difference in the lung sounds is going to be one of your key ones that really differentiates this one, and then pulmonary embolism similar depending on what side it's on. Um, Another ones that we can include is so whenever you have issues with your respiratory, what's the thing that compensates?
Cardiovascular, some like tachycardia. Would that be it or no?
Uh, Sorry, what'd you say?
Would it be tachycardia?
Sorry, I couldn't hear you. I think you were cutting off on my end.
Tachycardia?
Oh yeah, tachycardia. So your heart's gonna compensate. You're gonna have faster heart rate. That's typically expected as well. Other stuff that would make sense, and you'll tell you like, oh yeah, hypoxia. And then another one is pleuritic chest pain. So this is chest pain that occurs when you're breathing in deeply, which makes sense because especially it's in the name, plural, pleuritic. It makes sense if you're breathing in, if you're attempting to breathe in deeply, this lung is gonna attempt to expand it, but it's gonna have to fight against this pressure, so that's gonna hurt. Um, and what the reason I say some of this is vague is just because most of these symptoms here can also be found in like pneumonia and other respiratory conditions. So that's why it's kind of vague. This diminished absent lung sounds uh, is probably the one that kind of sets that apart from the pneumonia, other than pneumonia having uh sputum, like maybe could have bloody sputum, um, and things like that. But that's kind of, for the most part, that's why they do, the diagnostics, because that's gonna also help you tell what's going on. And in this case, also having maybe like uneven chest rise could be a thing that happens. Yeah. Although I think uneven chest rise is more typical with the tension pneumothorax. Okay. So, tension pneumothorax is a medical emergency. This one will require a chest tube immediately, and they don't really test too much on this one. One of the main things that is included here that's not, so it'd be like additional signs and symptoms. That it would be included from a tension pneumothorax. It would be what's called paradoxical breathing. So that means someone is attempting to breathe in, and that will actually make their chest deflate, and then breathing out will actually make their chest inflate. So that is one of the signs of tension pneumothorax. And one of the things that makes tension pneumothorax different from the other one is that you'll have tracheal deviation. So if you want to take a look at that, you can see here how the trachea is completely moved to the side in a tension pneumothorax. Yeah, it doesn't happen with a pneumo or hemo, just a tension pneumothorax. And part of that has to do with how it's affecting the airway in general, because it's completely deviating the trachea. It's going to cause some pressure on the heart as well, so it'll have some impact on your cardiac output from all that thoracic pressure. See, some of these pictures are probably pretty good. Let's see. I think this one's pretty good because it kind of shows, this one's pretty good actually. It shows the compression of the heart as well. It's from Instagram, okay. Second, let me take a picture. So we'll just, whatever, that's fine. Compressed heart leading to decreased cardiac output. And this is something that you can also apply, the concept of the compressed heart leading to decreased cardiac output, with other things that you'll get on in the future. Just having that thoracic pressure will cause the same thing. So once you guys get onto ventilators, that concept will come back. So we can, yeah, that's due to deviation. what do you call it? Deviation of the trachea. And so that is an emergency, the tracheal deviation. But again, they mostly just want to focus on this part right here, just the pneumo and hemothorax. But for the most part, they have the same signs and symptoms. The tension pneumothorax is like an immediate, you have to go immediately stick a needle. Okay. So what do you guys think might be some of the stuff that's done other than, I guess, I mentioned a few already, but some of the things you'll probably be doing. Any that you've maybe seen or not. Has anyone ever had a patient with a pneumothorax? No? Fair. I've only really seen them at UCI Lakewood because they keep messing everyone up when they. Oh, I forgot this recorded. Whatever. So the management, yeah, we'll be doing assessments on their O2, their lung sounds, breathing effort. And then the management's gonna include chest tube, and I do like the idea of also like the IS. But the main one's gonna be chest tube because that's the main thing that's going to help and drain some of that fluid and air. Yeah, so drain the blood and air slash air. IS to expand the lungs as much as you can. Something to note is that it is very possible that you get a pneumothorax from other procedures like a thoracentesis. Other things such as, so maybe we can put some causes. So a thoracentesis gone wrong, a central line gone wrong. And sometimes it could just be spontaneous. And more likely in like spontaneous, it could come with people with COPD, could get spontaneous pneumothorax. Tall, yeah, tall, thin men in particular, for some reason, are more likely to develop a spontaneous pneumothorax. Okay. Oh, and then obviously trauma. Okay, any questions so far on this? It's pretty straightforward. You get stuff in your chest, you get the tubes that get it out. Yeah. And these are self-explanatory enough that if you had a multiple choice question on it, you guys would probably click all the right ones anyway. The only one I know that not to get confused by is the tension pneumothorax and the paradoxical breathing. So just keep in mind this one only really occurs with the tension pneumothorax, and they call it a flail chest with the deviation. This one's not present in a regular pneumothorax or a hemothorax. So if this is a select all that apply, don't click the paradoxical breathing because this one's only the tension pneumothorax. Okay.
Just a quick question.
Yeah.
If the patient has pneumo or hemothorax, would it be painful for them to do IS, or would we like pre-medicate them, or is this okay to do?
It would be pretty painful just to because they're expanding the lungs and it's still going down, it's still kind of painful. there's pressure on there, it might feel a little tender when you're breathing in. It might have them. They might have some coughing fits. So, ooh,
Girl, what?
yeah. Did I not? Oh, I did. Oh, no, it's right here. Yeah, like, makes sense. Yeah,
Make sure it doesn't fully fall out.
yeah.
Ciao.
My wife really wants Jasmine to know that she likes her dog.
I like your dog. Thank you.
But yeah, that's kind of how that go. And then pleural effusion. Pleural effusion is when there is fluid in the pleural space. So usually this will be due to a lot of the causes. Actually, I guess you guys think of some causes that could cause. There's one that's probably the more obvious one that you guys are probably seen before because it's such a common condition in the hospital that would cause fluid to go to the lungs into the pleural space. Yeah, heart failures. You guys probably see heart failure all the time, especially on the floors you guys get put on. It's like, yeah, PH Whittier. It's like you guys see heart failure every day. Yeah, so heart failure, a few other ones. You could still include trauma in here. It could still cause some of that. And then some of the other ones include tuberculosis and pancreatitis. This is like a very niche, I would say niche on the. I don't even know if have you guys ever gone through pancreatitis? Because if not, if not, I guess I'm not allowed to talk about it, but I'll talk about it anyways. Yeah, just for now, just know that hey, you don't even have to know, but it's just it's something that happens. It's a possibility. It just when you guys go over pancreas at some point, you'll learn about it. But it's a niche one. The main ones you're gonna really think of is gonna be heart failure, tuberculosis, probably also like pneumonia as well. And the management for this, does anyone know the management for getting the fluid directly out of the pleural space? So as opposed to here, where now it is the amount of fluid is so extensive that it is putting pressure on the lung. This one's just there's fluid, there's additional fluid there, but not enough to cause this compression. Thoracentesis, yeah. So the thoracentesis, I've seen maybe like one or two uh get performed, and then I remember coming back the next week, the patient was still there, and then I was like, I wonder how their thoracentesis went, and then it's like they got pneumothorax from the thoracentesis, and then not relevant to this topic, but then on their note, it also says they got an acute kidney injury. So, oh, this was I think I talked about this patient last week. So they came back from their thoracentesis. Next week they had a pneumothorax and they had a chest tube, and they had now developed end stage renal disease after they had an AKI. So this guy got screwed over pretty bad. And he was nonverbal, so if he was in pain, he probably wasn't getting pain meds. So just thinks just stuff to think about. And then empyema, uh, this one's referring to pus in the pleural space. So this would be more related to an infection of naturally. So pneumonia would be a big one, and this one's the same idea as the pneumo and hemothorax, so chest tube. Any questions on this so far? So far, I think it's relatively straightforward. Fluid where not supposed to be, drain fluid out. And then you have a thoracentesis. So that is right here defined, but just the procedure to remove excess fluid air. They put a needle in and try to drain some of that. What is the positioning that they need to be at for the procedure to be done? And then as a nurse, you will be assisting with the positioning, you'll be assisting with the monitoring, and you'll be assisting with collection of the material as well. So doctor will want you when they come in, they'll want you to already have everything kind of set up. So what's the positioning that should be done? Head of the bed up, laying on the non-affected side. Uh, the general idea is there, but it's yeah, like Jasmine said, it's sitting up. So typically what they have them do is they literally will yeah, exactly. So this is that would be yeah, after. So this is like during. Yeah, I guess I'll specify positioning during. Uh so the positioning or rather prior to procedure. So this is the one that the doctor will want them to be already prepped up at this position when they come by. Or they're gonna yell at you, I guess. And they're gonna want all their tubing stuff, all the not tubing, they're gonna want the supplies already set up. So positioning prior to procedure, they're gonna be wanting to be sitting up, and you're gonna want them sitting up. And what you'll do is you'll take their bedside table, set it up in front of them, and they will kind of lay over it, kind of like a tripoding position that someone with like COPD might be in because they're struggling, but it's the same idea. So the concept there is it allows for easier access to the area that they need to drain. Um, so sitting up, leaning over side table. Okay, and I'll get a picture of that, so why not? So, pneumothorax positioning. So this got a few, but usually it is leaning over. That's more like chest tube. Oh, I don't know why I put pneumothorax positioning. I meant thoracentesis. Yeah, that makes sense why I was getting chest tube position pictures. Like, why is there all chest tube pictures? This one's pretty solid. So the chest tube would be if you're having to drain a lot of fluid, like continuously over time. So that would be more appropriate for like so the main difference here between a pneumo and a hemo and the pleural effusion. Pleural effusion, you're gonna have fluid in the pleural space, but not to the point where it is built up so much that it is pushing and causing all this pressure on the lungs. So it will not look like this, for example. So if you want to see if we can try to take a look at, um, I have this picture ready, I guess, to go. So we can take a look at the pleural effusion. Um, so sometimes this one's probably a bit closer. You have some consolidates, but you don't see the same level. I mean, I guess it might depend because look at this one. This one's a little bit more, but this one's more gonna be in the area rather than pushing up on the lung. So this one's labeled and everything. So right here, I guess it shows a little bit of pleural effusion right here. So kind of around that pleural space rather than being so I would say like the main difference is really that the hemothorax, pneumothorax, that pleural space is kind of has been punctured, and all of whatever is in there, so either air or fluid is starting to leak in to this lung space and then pushing against it. The pleural effusion is fluid in the pleural space, but like actually in the pleural space. So what's surrounding the little sac surrounding the lung. So it's not going to be as much in terms of the pressure being put against here. So on that one, you can get away with the thoracentesis. It's less emergent. The chest tube is more is more for more higher higher acuity, I guess you could say. The chest tube is more for more emergent situations, while the thoracentesis is a little bit less so. And the pleural effusion can wait, while a pneumothorax and a hemothorax needs to get that chest tube in pretty quickly. Because sometimes you'll have people with minor pleural effusions, they might not even get a thoracentesis. They might just be getting diuretics or something. And then they'll just be monitoring the chest X-ray. So it's kind of just based on the level of severity. But thoracentesis for the pleural effusion, because the pleural effusion is usually not as bad, but the other ones, because of that buildup is so bad, it's putting the pressure in. You want that fluid out as quickly as you can, so that's why the chest tube is put in place. Does that make sense?
Yeah, thank you.
Okay. What are some things you guys think you would be monitoring before and after? So kind of before and after, as in like things that you're comparing and contrasting before and after the treatment, or during and after the treatment. Yeah, definitely the lung sound. So just put respiratory status, their O2 sat. Yeah, so that's going to include their lung sounds, their O2, their respirations. WOB, is that, or is that did you mean SOB, or is that like work of breathing? Breathing effort. We'll count that as breathing effort. Yeah, chest X-ray should be 100% done just to assess the effect of the procedure and to rule out pneumothorax, because it could happen. A pneumothorax slash hemothorax after after the thoracentesis. Like I mentioned with that patient that got thoracentesis, and then they did a chest X-ray. It's like, oops, we punctured it all the way through, and now they need a chest tube. So yeah, chest X-ray is going to be a big one here. Other things in general vital signs, yeah, monitoring the incision sites. So you're gonna be watching out for bleeding, bruising, infection, because it's a procedure. So anything that was, I guess puncture site, monitor the puncture site. But yeah, bleeding infection is always going to be a thing you're looking out for. Maybe looking out for hematoma. In which case, infection, you're gonna have to call. Bleeding and hematoma, you can put pressure. You have to put a lot of pressure and then call someone. Okay. And then one of the things for the vital signs would probably be a focus on the BP, because they just lost a lot of fluid. Yeah. Fluid loss due to fluid shifts. So you had a bunch of fluid shifts happen. Okay. So the complications is basically what I've been mentioning. It'd be a pneumothorax or a hemothorax in particular, if they don't do it properly. Okay, and some of the things you guys already kind of mentioned for the monitor for respiratory issues, monitor for pneumothorax, hemothorax, and that would be based off your symptoms and kind of like continuing to get that point on like what's the difference between the pleural effusion and the hemo and pneumothorax? It would just be severity. So with the pleural effusions, the patient might have a harder time breathing, but they're not going to be in distress, while the pneumothorax, the patient's going to have all of this stuff go on, which is why they need the more, I guess, the more invasive procedure, which is the chest tube, because that's invasive to go in, and then you have something going directly into your lungs, while the thoracentesis is an in and out. So you can kind of compare that to like a Foley versus a straight cath. A Foley means that they're having long-term chronic retention, while the straight cath is like a short-term one-time thing. So you can kind of use that logic to kind of help get that picture across. So you're going to be documenting the fluid output, the color, and amount. Fluid output, color, and amount. So whatever color it is, whatever amount it is, you'll document that. And naturally, you're collecting the stuff. So we're collecting the drainage bottles, and then it's part of your job, I guess, before the doctor gets there to have all this draining bottles already in the room. So you're gonna set them up in their positioning. You're going to get the drainage bottles and just have their supplies set so that they could just go ahead and do it once they actually get there. And then Eric mentioned the positioning here. So positioning after the procedure was going to be head of the bed up and then on the unaffected side. So they usually say that's like the good lung down. So patient lay on unaffected side with head of bed up. And then the easy way to remember is just good lung down. And that's a similar justification as for why you had like COVID patients be in the prone position. It's the idea would be you have better having the good lung be down, or in this case it would just be the prone position, in which case they're both down, uh improves the respiration, helps get better breathing across. Mhm. So better respirations and also preventing the collapse of the alveoli. So that's kind of the logic behind that. Mhm. Any questions on thoracentesis? So main thing, you're gonna do a chest X-ray after. You're going to be monitoring respiratory, which makes sense. Uh, this is the positioning, something that you'll probably get tested on, and then the positioning after you'll get tested on, for sure. And then knowing the complications and what you're supposed to monitor is important as well. Okay. And then chest tube. Have you guys been oriented to the chest tube in Skills Lab at all yet? Yeah. Oh, that's good. Did they use the atrium? I think that's the most common one I see. Like this, pretty much this exact one. Yeah. All right, that's good. So these are disposable, so you'll get them from your supply room, set them up, and then if they're about to get filled up, you could just throw this away, grab another one, and kind of go from there. You can kind of see this picture here, you can kind of see here, you have that pneumothorax here. You can see by this left lung being compressed, and you're getting rid of whatever fluid, maybe a little bit of blood that's in there. In this case, maybe it's pus. So that's going to be draining through, and this is kind of old school right here, but that's what's happening here. Essentially, what's happening here is you have a site that collects fluid, you have a water seal that's able to detect if there is a leak of air, and then you have this pressure, this little pressure thing that's applying the pressure to make the draining happen. So same thing applies here. You have this draining chamber, so it's going to go down, and it's going to be your job to just kind of take a look at it whenever you're in the room. You're just going to take a look and kind of just keep a mental note of how much it has been draining. If there's a sudden stop of your drainage, that's bad. If there is a sudden rapid increase, that's also bad. Rapid increase means maybe something punctured again, and you're having too much output than expected. So that's bad. They're bleeding internally, or they're having another leakage of air in their lung internally. So you'd call the doctor for that. If there's a sudden stop, that could be an occlusion. So that could either be chest tube side or it could be something internal. So that's something that's also for you to kind of take note of. But otherwise, you will grab your marker and just mark your spot at the end of your shift and then document the amount of fluid that was drained out. So that's what this part of it is all about. And then this part right here is going to be your water seal. So your water seal is there so that you know that there's no leakage. So if there's air bubbles in here and there's there's gonna be like a number system that tells you how severe the leak is. But those air bubbles are a sign that there's a leak, and then there's this whole procedure that you do to try to determine where that leak is coming from. And something that confuses some people sometimes, especially when it's like a written exam. So this I think it's on the water seal. The titling. So this little portion here can go up and down based on their breathing patterns. So whenever they mention titling, that's expected. That has to do with their breathing in and out. So I think the water will go up when they're breathing, go back down when they're breathing out. So that's expected. Okay.
Well, that's a good one. Come on, that's a good one.
Yeah, so that goes on there, and then you have your suction control. You're pretty much always you're gonna set it up to whatever the order is, but very typically it's going to be -20 mmHg. But you're just going to set this up to 20, and then you're going to crank up. This is going to be hooked up to your suction. You're just going to crank up the suction part of it up until you have you're going to have this little accordion right here. As long as the accordion hits past this little arrow, you're good to go. That's going to be something that you're going to be checking whenever you're taking this patient on. So you're going to go into the room, see where the previous nurse marked their thing, check if there's any air leaks, and then you're gonna make sure that this you can kind of see it from this picture, but it's this yellow accordion gets at this arrow or past this arrow, and then that will be adjusted by adjusting your suction suction strength. And you can just crank that up because at the end of the day, this little pressure thing that says that you're gonna set to -20 most of the time is the pressure that you're actually going to be at for the chest tube, but the suction one can just be cranked up. So the suction one, crank it up just to get this accordion all the way out, and then this one will be the one that's actually regulating your device overall. So if there were to be some intermittent bubbling, which chamber do you think it'd be okay in? That's kind of written, but
Would it be the suction chamber?
yeah, the suction chamber. So here I kind of wrote it all down just so that it's kind of there. So gentle bubbling will come from the suction control. So the suction control would be not this part, but like this part, like around right here. Some intermittent bubbling is expected. So there's some expected bubbling there. It's also worth noting that continuous bubbling in the water seal is where it's really bad. There can be a little bit of intermittent bubbling in the water seal as well. And then that one's just kind of a sign that there is stuff being drained out. As long as it's not forceful and continuous, that's good. And everything here is kind of written down. So suction control should have gentle bubbling from the air being removed from the pleural space, and that's expected. Um, Once you notice that there's no bubbling in the suction control, that might be a sign for you to message and be like, hey, maybe they're ready to kind of start transitioning to removal to water seal, what they call it. They call it a water seal when you just straight up disconnect your just turn off your suction. If you turn off your suction, it's and just leave you could just leave the atrium, the machine as is, and then you just turn off the suction. That they call that just being a water seal. That means that there's no suction going on, but there's still that little bit of pressure from the suction control part that's able to keep things from collapsing. So you could just turn off your suction and it's fine. And that's the water seal. So usually if they're getting ready to be weaned off, they'll put them on water seal, which is just literally turn off your suction. And they'll see how they tolerate it, and then they'll go from there for the weaning part. They'll do a chest X-ray to confirm how it is, and then they'll take off the chest tube. And then for the water seal here, the explanation, it shows like what do you do if there is bubbling, and this can get a little confusing, uh especially if Jim kept the same audio where he like verbally messes it up, and then he's like, let me repeat that. I don't know if the audio for that, or if he used that same audio. Yep, he did. That's hilarious. Yeah, he's he's working harder, or he's working smarter, not harder. Love that for him. Okay. So yeah, so he did in fact use that same audio. So when you have bubbles in the water seal, that's a sign that there's a leak. So what you're supposed to do, and you're supposed to have this at the bedside, is you're supposed to have clamps at the bedside. So what you're going to do is you're going to be um, clamping it towards the patient's side. So um, you have this atrium here. You will clamp it towards the patient's side, so closer to where the patient is. If that bubbling continues, it means that the air leak is going to be at the machine side. If you clamp it at the patient side and the bubbling stops, that means that the leak is at the patient side. So if you see bubbles, you're gonna clamp it at the patient side. So you're essentially removing the patient side of it from the equation. If your bubbles continue, that means it's the machine and not the patient, and not a leak on the patient side. If the bubbles stop, that means taking away the patient's side away, make the air leak go away, which means that the air leak is happening from the patient side. Does that make sense? So clamping it takes away the patient side. If the bubble continues, that means it's the machine, or like the from machine side. If the bubbling stopped, that means it was the patient's fault, or not the patient's fault, but it's coming from the patient side. Did that make sense, or was that more confusing? Makes sense? Okay. So bubbles equals air leak. If you clamp at patient side, you're taking the patient out of the equation. If water seal still has bubbles, that means there's still an air leak, which means it's the system. And in which case you can just, because like I mentioned, these are disposable, you can just replace the system. And if the bubbles stop, that means it's the patient side. And you can't replace the patient. Although, if you offer them AMA papers, maybe you can. But what would you say is the priority if the leak is from the patient side? Yes. So you're gonna unclamp it and then call the surgeon, specifically the surgeon, and not just the MD. The MD is gonna be like, I literally can't help you. So you would be calling the surgeon that put the chest tube in. So, but you never leave it clamped. So that's going to be your key thing, is that you're never leaving it clamped. So you clamp to determine that there's an issue, but you do not keep it clamped, because then otherwise you can be building up pressure there, and that's not good to be building some pressure in the whole system or in their lungs. So we're going to be always unclamping it and then calling the surgeon that put that thing in. So during report, they'll probably be telling you they'll be telling you whoever was on the case. So you'll get whatever consults were done. And then for this procedure, you should also be told the surgeon that put the chest tube in, so that you can call them. If there is a leak and it's machine side, then you're going to unclamp and just replace the system. So what you can do is you can take a bottle of sterile water or normal saline, have it open. You disconnect the tubing from the atrium and then put that tubing inside of the water. So that's also another way of getting a water seal. And then you literally just grab your new machine, or you could even skip that step if you're not going to have them. If you're going to just disconnect it and reconnect it to a new machine, you can just do that. If for some reason, I guess I would recommend, if you continue having the bubbles after clamping it at patient side, so you're gonna unclamp it and just, either you already had an extra atrium at the bedside, which is probably the better idea, and then you just disconnect from this one and connect it to the new one, and then you're good to go. But if for some reason you didn't do that and you don't have one at bedside, you would just disconnect it, put it in the sterile water, and then go find one. So I guess in the scenario where supply room doesn't have an extra atrium and you never called supply room to give you some more, because they never tell you, because you probably won't know that you have to do that, because there's a lot of stuff they don't tell you, and then this could be one of that times. You can just have that sterile water and normal saline and then dunk it in there while you're waiting for the new chest tube to arrive. Does that make sense, at least? Kind of. So if it's the system side, you just grab a new one, unconnect from the old one, connect to the new one. If for some reason there's a delay in getting another one, just have your sterile water and put it in there while you're waiting for a new chest tube to arrive. Well, it's important. Okay. Any confusion on that? Because Kaylin is saying that I said that like 10 times.
Why are you gonna call me out like that?
What? Just threw a cracker at me. Okay. Okay. Yeah, just let me know if there's any confusion on chest tubes because this does confuse people a lot, and it will probably confuse you a lot when you actually have a patient with the chest tube, or when you're a new grad and they don't tell you, they just like, here's your chest tube patient. Okay, bye.
Hold on, it should not be. Let's take that back a second. Seriously, no, tell him.
But yeah, so Kaylin say if that does happen to you, where they just say, here you go, goodbye. She says, stand up for yourself.
Don't take it. Tell them you don't know what's going on. You've never been trained on the device. Tell them no.
Because it will happen on
And if you
a lot of
don't feel
places.
safe, if you do not feel safe, use cuss. Y'all remember cuss from like first semester? It comes back around. Promise. Promise me you'll take this advice.
I don't know if you guys got told about cuss. It's just keywords.
I did.
It's just keywords that you're supposed to use when you're uncomfortable. So I forgot what the concerned and then uncomfortable and then scared or something.
And then the last one was like stop or something.
Or stop, yeah.
So
So
stop, hold up.
yeah. So that's when those are the keywords that you're supposed to say when you're uncomfortable. Like the doctor's making a mistake or something and you catch it. You could be like, just like you could be like, doctor, I'm not sure. I'm a little uncomfortable with this, or
Uncomfortable, unsure.
yeah, I'm unsure, uncomfortable with this. And then they might be like, oh, they're like, oh, right, like, oops, I forgot, or something like that, or not. And in which case, you just got to move up your chain of command. So that would be your charge nurse, and then your house supervisor.
Don't be afraid.
And I guess Kaylin says, don't be afraid, but you will be afraid, honestly. But if you can afford to not be afraid, you can do it.
Well, no, if it becomes a patient safety issue, like, hi, just moved your face closer to me. If it becomes a patient safety issue, then it's beyond that. It's more scared not for yourself but for the patient. At the end of the day, that's what it should all come down to. Not because you want to appease somebody or try to make friends with the doctor or charge nurse or whatever the case might be. It's the patient could be in harm's way, and you saying something is going to stop it. Push the issue.
Okay. So any questions on anything so far? We're almost done, actually, to be honest. We just have to talk about what happens if the chest tube is disconnected, and some monitoring stuff, and then it's just practice questions that we can go over. Any questions on anything? Sorry, today was a little rambly, I think. Okay. So does anybody know what to do? What goes down if the chest tube gets disconnected? Like, what are you supposed to do?
Aren't you supposed to like put like yeah, Vaseline impregnated gauze
Yeah,
over the
exactly. So this is similar to have they ever gone over evisceration with you guys? Like like a wound? Yeah, the guts out. Yeah, the evisceration, guts out. Like you're supposed to put a sterile gauze yeah, guts out sterile gauze on there and then call someone. Same idea. You're supposed to put the Vaseline gauze. He likes calling it the Vaseline impregnated gauze, which is you know, it is what it is. I'm gonna write that. It's funny. Vaseline gauze, and then call a rapid or the doctor. Probably a rapid. And by doctor, I mean probably the surgeon. So we'll actually type the surgeon to be specific. So yeah, so at the bedside, what you're supposed to have is you're supposed to have 2 clamps and the Vaseline gauze. just in case, and then some emergency supplies. So this is respiratory. You might want to have some respiratory supplies, suction, nasal cannula, ambubag, that kind of stuff going on. You're not supposed to try to reinsert the tube, so do not do that. And then here is something I do think is very important is going to be the monitoring. We did talk about some of this stuff. So we're going to have at bedside, we're going to have their 2 clamps and the gauze, the Vaseline gauze. We're going to be doing 2 1-hour monitoring, allegedly. Basically, whenever you're going to the room to check up on the patient, you should just be checking out the chest tube, and you should be doing your checks pretty much the same checks you would as you're first coming in. Just check to see how much drainage has come out. If it looks like, hey, I remember it being at 100 and now it's at like 500, and it's only been like an hour, it's like, huh, that's a lot. Or it's like, oh, like literally no movement whatsoever. And the patient may be starting to feel like their vital signs are kind of getting a little bit off. That's something to worry. You want to still check out the water seal, and you still want to check out the accordion to make sure that's fully out. How much drainage is too much drainage from a hemothorax? Yeah. So this is what we were told. We were told too much. It's kind of mentioned a little bit here, but too much once they're already kind of stabilized and most of the stuff has been drained out. Too much drainage, and it depends on your policy. So it might be between 70 to 100 mLs per hour. Could be indicative of hemorrhaging. So too much drainage is about 70 to 100 mLs per hour, more than that. And you're also concerned if it spontaneously stops draining, which could be obstruction, could be a DC. But when it's initially put in, it's expected that you would have closer to maybe 200 mLs, or like just like a really high amount. Just like a really high amount in the very beginning, maybe like 200 mLs per hour in the very beginning. But most of the time, when you get this patient on your floor, that chest tube has already been stabilized. The patient's already more stable, and they don't. You're really more just focusing in on probably closer to this number or whatever your hospital policy is on it. And then kind of like I mentioned before, this is similar to a similar to a Foley catheter in terms of the chest tube should be removed as soon as it's no longer needed. And then you will be doing some trials, like I mentioned. You will be putting them on, you'll get an order to put them on water seal. So just turn off your suctioning, keep the atria on. Keep the atria on, and then just turn off your suction, and then kind of give it a go. See how they're tolerating it, and then after that, you'll get a chest X-ray and kind of go from there. So kind of mentioned here. They will water seal, take off suction, repeat chest X-ray after 24 hours, and then if they feel like that's resolved, they'll take the chest tube off, and then you'll just be recovering from that, and then you're going to be doing your checks like your incision checks. So you're going to be checking for infection, bleeding, hematomas, and all that stuff. But yeah, I would say your focus is on the understanding of the water seal, the understanding of what it means for the air bubbles, and then how, like, where do you go from there? You clamp, make the assessment, is this patient side or machine side? If it's patient side, you're going to unclamp, call the surgeon. If it's machine side, you're going to unclamp and just grab a new one, replace it. If for some reason you can't get another atrium, you're going to get a bottle of sterile water or normal saline and just dunk it in there. If the chest tube comes off, you're gonna put the gauze and then call rapid or surgeon, and both, probably both. If you see titling, the keyword titling, that means the water in the water seal chamber is gonna go up and down with their breathing. And then the suction control, if there's bubbling there, it's expected. And maybe even a little bit of gentle bubbling in the water seal can be expected, as long as it's not continuous. If it's like intermittently, that's expected and it's normal. Yeah. Because essentially it's kind of some of that is just from the fact that you are draining some stuff, especially if it's a pneumothorax. You're not draining water, you're draining air. So some of that coming in is expected. And then there's monitoring. So the things to have at bedside. What is too much drainage, etc. here. And then we talked about the thoracentesis. What's important here is highlighted. For the pneumo or hemothorax, focus on your signs and symptoms. What's your interventions, etc. So that should be pretty solid on that. Yeah, that's pretty much it. I do have some practice questions for you guys to kind of do. Just based on these questions, looks like I wrote it. So we're and not Kaylin. So wait, she's what? What? It means my questions are really good. No, actually, I think these are your questions, if I'm being honest.
Is it mine? Wait.
I can't tell. They're long, so that's why I figured it was mine, because
That first one's not mine.
I'm like, I make it extra for no reason. But
Somebody asked.
oh no, I already answered that. So number one, a 72-year-old man with a history of COPD presents with sudden shortness of breath and right-sided chest pain. He is on 2 liters of oxygen via nasal cannula. You assess him and find these vital signs. So he has a respirations of 30 per minute, heart rate of 112, blood pressure of 134/76, SpO2 of 88% on those 2 liters. He appears anxious and is using accessory muscles. Breath sounds are absent on the right. Chest X-ray confirms a large right-sided pneumothorax. The MD has ordered a stat chest tube insertion and is on their way. How would you approach the situation? Yeah, I definitely wrote this one. And this is, yeah, you're not going to get free answer questions, but I like having some of the free answer questions just as good practice. So type in the chat kind of what you think, and it's no answer is wrong answer. So what is the first thing that pops out from this question right here? You don't have to answer it immediately. You could just start. You could write down your thought process here. So what's the first thing that kind of comes to your mind, or say it. That's fine too. So say this is literally your patient. You come into the room, be like, "Hey, Mr. Jenkins, what's going on?" And they're like, I'm feeling chest pain in my right side I'm having a hard time breathing." And then you take their vitals. This is their vitals. What do you do? This is literally like you right now. What do you do?
I was gonna say that looks pretty normal for COPD. think there's some other stuff that pops out.
Yeah.
Definitely other stuff pop out.
I like both of these responses here. So yeah, elevate the head of the bed if it's not already elevated. I'd be very surprised if it's not. But if it's not, you want to elevate it. High Fowlers help with some of that breathing. Maybe titrate. Actually, the O2 is actually technically doing okay because they're COPD. Yeah, just kind of monitor the patient. Some of these vital signs can actually just be straight up normal for COPD. But if the patient is having accessory muscle use might also be
still gonna be.
COPD, but they have the breath sounds are absent on the right. That's a big deal.
Bro,
And you know for a fact that this is a pneumothorax. There's gonna be a stat chest tube insertion.
Jesus.
So you're gonna wanna focus in on like Eric said, head of the bed up, maybe whatever you can for comfort measures. I like the idea of checking like the coagulation factors if they have it there because they're gonna get poked. That's fair. Although it's worth noting that even if it was abnormal, they'd probably still do it just because that's gonna be more effective.
You shouldn't be bleeding.
Okay. Any other thoughts on this? So Kaylin was just mentioning so right now they confirm it's a pneumothorax, I suppose. But if it were like a hemothorax, you can kind of that's kind of where the taking a look at the coagulation factors would be good, just to see like maybe it's a spontaneous one or did something crazy happen. And it'd probably be spontaneous in this situation. But get the patient actually for it because this is actually a chest tube insertion. They have a slightly different positioning for that. So chest tube insertion would not be leaning over the bedside table. It would be more laying down like this.
Chilling, fat chilling.
And then they're gonna insert it while they're kind of laying down with the head of the bed up. Yeah.
I was right. The baddest guess on that. Like fifth intercostal.
Yeah.
Right.
So fifth intercausal space, you don't have to know that, but just so they lift up, expand that area, put it in, and then they have the here's this one that's going on. So yeah, that's a different positioning for the chest tube insertion versus the thoracentesis. But yeah, that's all good approaches. I was just kind of trying to see where we would go, like how would you guys respond if you get like a similar kind of question or just in case you were wondering, like, where were you, like, what are some of the things you might want to do? Because you're going to find yourself in situations where you've never experienced this before. Where do you go from here? And you will probably have an answer now and then kind of be lost for words when it's actually happening. So sometimes trying to really put yourself in that situation, get the shock factor out of the way first, and then next time maybe you're gonna be in a little bit less shock. I think it's always kind of worth exploring. Like, how would you react if you were in this situation? If you've already kind of thought about it and gone through some of that initial shock, because you will have some initial shock just from the fact that this is happening to you now in real life, and you're the nurse now, and you're the person in charge. Uh, like all of that stuff is gonna get into your head, and you really want to just kind of get that those thoughts out of the way so that you can act appropriately. And yeah, so all you can do here is some of the basics. So you guys got some of the basics out of the way. That head of the bed up, all that stuff. That's kind of like basics that they drill into you, but I just wanted to kind of put your brain into the situation and then just kind of notice that in this moment you're probably going to want to do just the basics. All you have to do is the basics. It's just high stress situation though. Would you pre-medicate with pain meds or doctor going to apply local anesthetic? I think they just actually I think they would just apply the local anesthetic. So and this is another thing you could do is also you could call a rapid if you want to. I mean, they're already doctor's already coming, but if you feel scared, if you feel like you don't know, you can always call a rapid, call for help, call another nurse to come over and kind of help you out. Yeah. Anyways, right here, this one we just directly talked about it, but which one of the following items would be in the client's room after having a chest tube placed? Select all that apply. Yeah, A, B, C, E. Everything except the catheter. It would just be having oxygen, having the sterile water so that you can apply that if you need to go water seal and you don't have anything. Occlusive dressing, yeah, so everything there. Number 3, you're caring for a patient who has a chest tube and a drainage system in place. So that's the atrium. When you do your rounds, you notice that the chest tube was removed from the patient. What do? You guys already mentioned it, so that would be applying the sterile gauze to the insertion site. Just smack it on. What do you do if the chest tube becomes disconnected from the chest drainage unit? So if and this can happen. This can definitely happen. So what you want to do usually with your chest tubes is get a bunch of tape on the bottoms of the little atrium and just kind of have it all be sticky so that you can kind of put it on the ground in a spot and have it have some keep it grounded so if like someone accidentally kicks it, it doesn't cause the whole thing to shift down, like to shift over, or that nothing can really knock it over as much. So there's not as much movement going on, so that stuff doesn't get disconnected. But if stuff does get disconnected, what can you do? And then this is talking about just like disconnection from the atrium. Yeah, the tube and sterile water. Put the tube in sterile water if you don't have another atrium. Yeah, so that's why you have this as a supply that's already there. So you can just put that in and then you go looking for another atrium. Or if you already got some extra atriums, which is probably recommended just in case. So you're not looking for one after or maybe you see that there's one in the supply room, just grab it. So it's not like there's one in the supply room, but then someone else needed a chest tube, so they took it, and then now there's none. So just kind of take yours and get your extras in the room, or just put in the sterile water while you're waiting. Okay, and then the last one, you're providing care to a patient with a chest tube. You note continuous bubbling in the water seal. What is your intervention? So bubbling in the water seal. Yeah, so if you see continuous bubbling in the water seal, that's a sign that there's an air leak. If it had been intermittent, it could just be a benign just because it's draining. So these were pretty easy questions. I'm not sure how the test is gonna be. I have a feeling he reuses, honestly. Well, actually, I don't know. Probably shouldn't be talking shit, but respectfully, might be similar questions that the previous classes got. So if it kind of remains with that style, you'll probably see things be a little bit more complicated than these. These are um pretty like obvious answers, I suppose. Like once you like really dive deep into all this stuff. So you might get a little bit more complicated type of questions. So I always recommend Quizlet. So you could do Quizlet and search like Quizlet pneumothorax, Quizlet pleural effusion. Yeah, and just make sure it matches the content being taught. Sometimes it doesn't. Alternatively, you can do Quizlet, search the name of your book and the chapter, and then kind of work with some questions that are in your book if you don't have the book physically or online. You can do some practice questions there. Just to get the general idea, but this should get the general idea across. Everything that's highlighted are things that I think you guys should focus on and that could be asked. But yeah, those are your exemplars. Any questions on that? All right, that sounds good.